My name is George Weiner, and I'm the immediate past president of the consortium and the director of the Holden Comprehensive Cancer Center at the University of Iowa. And it's my privilege to moderate this session on precision medicine and its impact on cancer. We have 4 panelists, 2 here in person and 2 here in larger-than-life form on the screen. So I'll go ahead and introduce them briefly, and then we're going to just jump right in with a series of questions about precision medicine and precision cancer care. So we'll start out with Jackie Cale. Jackie serves as the Iowa Government Relations Director for the American Cancer Society Cancer Action Network, which is the advocate affiliate for the American Cancer Society. Next to her is Dot Guccione, who is a senior biomarker testing account executive for Genentech Bio-Oncology, and she previously had experience as a medical oncology nurse, which gives her an in-depth knowledge of oncology and biomarker testing. On the screen, we have Dr. Colleen Campbell, who is the Director of Genetic Counseling Operations at the University of Iowa. Dr. Campbell has successfully led the Iowa legislative effort to license genetic counselors in Iowa, and is taking her incredible energy and passion at the national level, where she's now leading the National Society for Genetic Counselors Advocacy Coordinating Committee. And then finally, Bryce Olson is a Portland-based tech and an internationally known patient advocate for genomics-guided precision medicine with deep connections to the industry. And he started a patient-driven movement called Sequence Me to help other cancer patients improve their genomic IQs. So a fantastic and very diverse panel. And what I'm going to do is I'm going to ask a series of questions here and just allow them to speak from their perspective on their thoughts on these questions. So I'm going to start out with a very straightforward question, and that is that many would claim that precision health is not a new concept. Indeed, surgery, if you think about it, can be considered precision health. It's giving care to one patient at a time. What are your thoughts on your interpretation of the meaning of the term precision health today? And Jackie, why don't we start out with you?
Is this on? Thank you. So my name is Jackie. I'm with the American Cancer Society Cancer Action Network. Thank you to the consortium for inviting me on this panel discussion. Thank you to Dr. Weiner for moderating. I don't love that I'm starting first. I do not have a medical background. My background is in policy and advocacy. So I will defer to my other panelists when that comes to more of the medical side of precision medicine. But one thing that ACS CAN is doing, we focus on how do we get this precision medicine out and in front of the public. And what we think when we think precision medicine is each patient is getting the right treatment at the right time. It's breakthrough with new research and technology that has happened over the past years. It's very exciting science, and we want to make sure that everyone knows about it. And then what we do as ACS CAN is make sure that we can advocate for everybody to have access to this new treatment.
Doc?
Is this on? Can you hear me? Yeah. Okay. Well, I'm going to steal from the National Cancer Institute's definition of what they say precision medicine is. And it really is a form of medicine that looks at a person's genes, proteins, and their lifestyle and the environment that they live in, collate this to prevent, to diagnose, and to treat disease. So what does all that mean? Well, and it can mean a lot, but just I'm a biomarker specialist, so I dive into biomarkers that really identify the type of disease the person has that makes that cancer, that specific cancer, grow. Well, we've started doing this probably in the late 1990s, 97, 98, where we really had a drug that came out that looked for at breast cancer and found a new biomarker that worked in breast cancer. And it revolutionized, but was the very first drug that actually looked at the pathophysiology of the disease and the pharmacodynamics of the therapy and kind of merged them together to get positive outcomes. Well, when I say this revolutionized breast cancer, it truly did. With that concept, we have now moved forward with other diseases and identified them specifically through biomarker testing, identifying the dysregulation, what's going on, and then taking that to the final step and saying, how do we treat this? Bringing in that pharmacodynamics of how do we put this together to make better positive outcomes than we had previously with our other therapies.
Thank you.
You're welcome.
As I strain my neck here. Colleen, your thoughts? You're on mute, I think.
Thank you. Sorry about that. Thank you, Dr. Weiner, and everyone for the invitation to speak today. So I think, you're right, George, when you say like precision health is a term that's used a lot. It is. I also think it's a term that evolves based on our current knowledge. And while we thought we were performing precision health or precision medicine, we now know that what we thought was precise may not have been as precise as we previously believed. Oh, a lot of P's there. For example, breast cancer is not the same in everyone, and we know that now, but we didn't know that 20, 30, 40 years ago. And as a geneticist, I'm going to be biased, but I can say like we now can use the genetics, and we know that genetics as well as other sources of data can help us inform us more precisely about not only the origin of cancer and what drove it to begin, but also what treatments may best target the tumor and how, in addition, how patients may metabolize medications, which is known as pharmacogenomics. So I'll stop there.
Okay, thank you. And Bryce, from your advocate point of view, what are your thoughts on the term?
Yeah, I really think, and I think somebody mentioned this already, I think it's right intervention, right person, right time. We move away from a one-size-fits-all approach where everybody gets the same, treatment pathway, and you really individualize things based on what's driving somebody's disease. And then you use a bunch of other data sets that are also unique to that person, and you give the right intervention at the right time for the right person.
Okay, thank you. So I had prepared a list of questions, but I'm going to go with a question that I didn't prepare, partly because of the fantastic discussion we just had about disparities in Iowa. So, and Jackie, this should be up your policy avenue. What can we do to assure that advances in precision health reach everybody, including those who have less access to healthcare in general?
Yeah, so that's a great question. I was thinking about that as we were listening to the panel before, so I really appreciate the insight. And I defer to all of you on what we can do to help have this access reach Black Hawk County, Waterloo, because obviously we don't have all of the answers, but one thing that we are doing at ACS CAN is advocating for coverage with Medicaid. So we know that people on Medicaid are less likely to have the same resources or the same access or even the same knowledge about, innovative technologies like precision medicine, like biomarker testing. And by making sure that Medicaid covers comprehensive biomarker testing, we're expanding that base. We're making sure that everybody has access to this innovation. I was listening to a panel last week. They were talking about biomarker testing in Minnesota, and one of the doctors on that panel said that innovation is fantastic, but it can also create disparities if we're not providing that innovation to everybody, and we don't want to do anything to widen the disparity gap that already exists.
So I may just jump to Colleen and say that, that precision medicine and innovation is not just the molecular testing. It's also counseling patients about what the results of that testing means. And that obviously needs to be done differently for different populations. What are your thoughts on providing counseling to people from various communities, and how do you how does your field help assure that the language being used is language that can be understood?
Yeah, I mean, I think that's what genetic counselors are known for, right? Is communicating the complexities of precision medicine and molecular testing and the results, not only to the patient, but also to the providers, right? Who are being inundated. There's 14 new genetic tests launched every day in this country. There's just a ton of information coming out. And so to help the healthcare team really stay on top of what's best, I think that's the role of the genetic counselor. And one of the things we're doing, you know, sometimes people will say there's a shortage of genetic counselors. And we actually, I would push back against that. I don't know if there's necessarily a shortage, rather there's more of a distribution issue. So if we look at Iowa, there's 27 genetic counselors based in Iowa City, and there's 3 in Des Moines and the Des Moines Ames area. That's a distribution issue for our state. And we know that hospitals, I get calls all the time from hospitals that want to hire genetic counselors. They want to offer these services, but they don't know how to pay for it. Because right now, genetic counseling is actually a covered Medicare benefit, but genetic counselors are not yet recognized as Medicare providers. So it's kind of a weird catch-22 there. And so one of the bills that I'm really passionate about on the policy side is House Bill HR 2144 and the companion Senate Bill S 1450, which is the Access to Genetic Counseling Services Act. And what this will do is recognize genetic counselors as Medicare providers. And why I'm so passionate about this bill is because of all those calls I get from hospitals who want to hire genetic counselors, but they're not sure how to pay for it. And so this would enable genetic counselors and their hospitals to get reimbursed for those services so that we can, you know, start working on this distribution issue that we really have. The other thing that bill will do is allow genetic counselors to provide and get reimbursed for telehealth, which I think is obviously really critical in a state like Iowa that's so rural. So I think, you know, I'm biased, but that's one of the bills that I think will really help with the access, hence, you know, the name of the bill. But we do need to work more on, you know, how do we help people from all different backgrounds. I'd say the other part of that is that we need genetic counselors who are from different backgrounds. And so one of the things we focus on a lot at the University of Iowa is trying to engage, you know, students to enter this profession who are from rural Iowa and want to, you know, go back and work in the rural setting and understand the needs of rural patients better than, you know, somebody from, you know, a larger city may. And so I think not only the needs, but also the challenges, I think, that face rural patients. And so that's something we're working really hard on is, you know, to diversify the population of genetic counseling providers and, you know, doing that in a lot of different ways. Diversity can be, it's a very broad term, right, and can mean a lot of things. And so not just looking at race and ethnicity, but looking at all the elements of diversity.
Thank you. Dot, from an industry point of view, what can we do to be sure that these advances reduce instead of enhance disparities?
That's a great question. And I talk a lot about lung cancer because it is still the #1 cause of death in cancers, more than breast cancer and prostate cancer combined and colorectal cancer. So I think that we really have to get the message out. One of the things that I have been working on is educating nurse navigators on how to talk to patients about not only lung cancer, but biomarkers and what does that testing mean, and what about the terminology? I mean, we talk about genetic versus inherited. What does that mean? Genomic, you know, genomic profiling. It's so confusing. And as healthcare professionals, we forget that we're talking to lay people who've never heard this term. And one area that I think is really important is to distinguish between inherited. What is that? Your DNA that you were born with, that came from your parents, versus somatic, which is 90% of cancers are somatic. They are environmental. We don't always know where they come from. Yes, smoking is one of them. You know, pesticides is another one, but there's a lot of environmental factors that play into the role of developing cancer. And we have to educate not only our nurses and our healthcare professionals about how to properly talk to patients, but we have to educate the community about this. It's just critical that we do this, because we will never have people understand the importance of a diagnosis with this type of biomarker testing if they don't understand what it means.
Thank you. Bryce, what role can patient advocates play in helping address disparities through precision health?
Yeah, it's critical. It's kind of something that I started with the Sequence Me thing that I did several years ago, where it really wasn't about any individual cancer. It was just the importance of understanding what drives your disease and how that can open up new doors. And all patients, especially once diagnosed with advanced cancer, they need hope. They need additional doors to be opened up, because it's mind-boggling how fast you can exhaust the standard of care therapies that are out there if you're an advanced cancer patient. And then what do you do? With only 5% of patients going into clinical trials today, that means 95% of these people are just going through the standard of care and then moving into palliative care and then dying. So that's just unacceptable. So greater education, but then again, to reach a diverse population, you've got to go where they are. You've got to figure out ways to, meet those people where they're at, and, again, use language that will work. But I think also the diagnostic testing companies, the big commercial diagnostic testing companies like Foundation Medicine and Tempus and Caris and Guardant and folks like that, they've got to also, proactively work with hospitals to get samples that are more diverse. We all know today that a lot of the databases are full of Caucasian samples. And, I just think that they need to invest together with the hospitals to really proactively go after diverse populations and to understand some of the unique drivers that are going to be unique to those people, and, build those databases, because right now it's heavily Caucasian, really.
Okay, thank you. So why don't we move on to another question, and that we're making progress in cancer research faster than ever before. And how is this progress in both diagnosis and therapy allowing us to take the concept of precision health to a new level, including things that we couldn't have imagined a few years before? I think I'm reading Bryce's shirt that says sequence, and I don't want him to be sequenced last for each of these questions. So maybe we'll go ahead there. And from your point of view as an advocate, what do you see on the horizon that you think will help patients most?
Well, I wouldn't be talking to you right now if I hadn't benefited from the advancements in precision health. I would have died years ago. I got diagnosed almost 9 years ago with super aggressive metastatic prostate cancer, and I burned through the standard of care real quick. And that's what happens when you have a super aggressive cancer. You become resistant to drugs real fast. And so, I got lucky. I was fortunate. I got exposed to the power of genomics and was able to have my tumor sequenced. And I found out that I had hyperactivity along a cell signaling pathway that had drugs in phase 1 that were being developed and tested at different sites. And I just basically said I wanted to do that. And, it was interesting. My doctor originally said, well, why do you want to get sequenced? It's not going to change what I would offer you. And I said, I don't really care what you're going to offer me. I want to know what's driving my disease, so then I can get into something that might be an off-label drug or a clinical trial. And I was super successful with that. When I identified that I had hyperactivity on this one pathway, I found a drug. And when I called up the pharmaceutical company for it, I said, hey, I want into your trial. They were like, oh, I'm sorry, we don't have any space available. And, they've all been filled. I said, yeah, but I got genomic sequencing data. They're like, you have what? I have genomic sequencing data. I know I'm a perfect molecular match to the drug you're trying to test. And she said, wow, no one's ever called us and said that before. We will absolutely make a spot for you. And so And I've done this. I've kind of, rinsed and repeated this strategy numerous times where I understand, I do the diagnostics with commercial diagnostic testing companies like Foundation Medicine or Tempus or Caris, and I identify what's driving the disease. And then I go and find a drug that's a good, usually works for a while. And, I'm looking at cancer as kind of a manageable disease right now. And I wouldn't have gotten here without the ability to do that, to open up new doors with precision health. So.
Thank you. So, Colleen, I don't think there's a profession where the advances are moving more quickly than in yours, going from, small panels of genes you were analyzing to whole exome and RNA sequencing and methylation patterns and circulating DNA, et cetera. Where do you think this is going to take the field, and how are you going to keep up?
Yeah, no, that's a great question. I think it's where I hope it takes the field is more in Bryce's direction, where more patients do have access to be able to do these things and find out what, is fundamentally driving their cancer and what causes it, so that we can get better treatments. I think, there's a lot of technology we have to think about with how to keep up, right? And the best way to do that. And I think, the panels are good. Single gene testing is good if you know what is that there's a familial variant or a mutation in your family that's causing the disease. But I think really we need to be moving to everyone eventually getting closer to having the whole genome plus the RNA-seq, and doing, like I think it was Dot mentioned, both your germline, what you were born with, as well as, somatic, what your tumor has, or what you've acquired. So I think we can build on the information and then develop those new therapeutic approaches, or, Bryce's newest treatment option. I think his story is so inspirational, and it's really not a new drug, his latest drug, but it's something that has been around a while and is easy. And I think that's really equally as exciting. I'm hoping not everything's going to be these really expensive new treatments that come out, but we'll be able to repurpose some classic drugs that will be more accessible to people as we improve the knowledge. But I think what that takes is more people knowing about it and knowing the options and asking, and not just the patients, but also the providers, and asking what is available to their patients. I don't know. Bryce's stories always inspire me a lot with thinking about how to improve, the patient care.
Thank you. Dot, from an industry point of view, where do you see the field going? I mean, it's moving forward so quickly on so many fronts.
Yeah, and just to give you a little idea, I was in clinical practice when we first understood that there was a driver mutation for breast cancer. And we had to wait until the patient was in the late stage to even test the patient. But what I saw from, my viewpoint, I saw patients, get off a hospice and get out of their wheelchairs, go back to work. It was amazing. That was the beginning. There was nothing then for other cancers, but even today, we now have 9 actionable biomarkers for non-small cell lung cancer. That's incredible, and that's just in less than 25 years. We have number 10 at the FDA, but it's not ours, but it doesn't matter. It's that we are identifying, biomarkers, drivers that make these cancers grow, that we can put therapies, targeted drugs to, that can stop that. And people with late-stage lung cancer can live those 6, 7, 10 years until we find something else. But the other thing that I think is really critical that we talk about is early detection. Screening is so valuable. We don't want to be always treating people with the end-stage disease. Let's give them an opportunity to never see metastatic disease. Early detection, and the therapeutics, well, they work great in the late stage. What do they do in the early stage? That's what we did with breast cancer. We can do that with the other diseases too. But we have to get people identified, and we have to get their cancer when it starts, and we can test them, and we can find out if they have drivers, and we can take that forward. So where we can, as Bryce said, someday live with cancer as a chronic disease like diabetes and heart disease, but people live with it. And that's where I see them going, is continuing the research, continue to understand how our bodies are working at the cellular level to really bring out the opportunity to expose more people to this, and even beyond the cancer realm, talk about other diseases too that we have got biomarkers for, and the research that's going on with that. It's blows my mind sometimes when I think about how fast it's going and how furious, but probably education has to come to everyone, and that's from bottom top.
So Jackie, sometimes when science and medicine move ahead very fast, policy has a hard time keeping up. How do we assure that maybe we look a little, skate to where the puck is going to be with respect to policy, given the advances being made in precision health?
Yes, that's a very good point. Policy moves extremely slow. I think it took like 10 years to close the colorectal loophole. Still blows my mind. But so I think when we think about the future, we want to get as ahead of it as possible. So that's why we're thinking about how can we get this access out to people now as the advancements are happening now. But we can't do it alone. So when I think about it, I think about the individuals that are benefiting from biomarker testing, and they're living a better life, they're living longer, they're having a better quality of life from this innovation, and we really need to share those stories, and we need to share them with the legislators, that we can spew facts at them any day, all day, but having those stories come to the legislature where they are is really, really, really impactful. And we're going to continue to do that at ACS CAN. So if you are, in this work at all, we really, really appreciate you lending your voice to the cause, because it really does go a long way. And we're hopeful that we can change the mind of a few legislators in this next year.
Yeah, as a scientist and physician who's advocated both at the state and national level, I recognize I'm not nearly as effective as a patient who has a remarkable story to tell, like Bryce spoke about, when it comes to advocacy.
Yeah, and I notice the stories are here in Iowa, so please encourage your families and friends, because having them come to the legislature really does make a world of a difference.
Thank you. So a sort of related question is, care pathways have become very popular recently, and as an approach to try to improve quality and consistency in healthcare. And for some health problems, they work very well. However, they can get in the way of tailoring a treatment specifically for a patient from a precision health point of view. So how can we be sure such pathways take into account advances in precision health to make sure, as we've talked about, we get the right treatment to the right patient at the right time? And maybe I'll shuffle up the sequencing, and Jackie, come back to you again, since this is a policy question.
I actually don't have an answer to this question. I am going to pass it off.
Okay.
I did have this question prepared, but I don't have a question, and I would rather pass it off to an expert.
That sounds
on
fine.
the subject.
Does anybody want to take it on?
I mean, I'll throw something at the wall and see if it sticks.
Okay.
So, I mean, I think, I'm just thinking, all academic cancer centers and community hospitals, they have to have relationships with other folks that are experts at looking at this stuff, I think. So, whether that's, because, a lot of academic cancer centers will grow their own genomics driven expertise, but it gets pretty siloed. And I don't know if you can really compete with some of the bigs, like the Foundation Medicines of the world and the Tempuses and the Carises. So like building relationships with them so you can tap into the clinical decision support tools that they have. And then also, just benefit from all the data they have. Like some of these places like Tempus Foundation Medicine, they have a third at least of all cancer patient data out there, so building those relationships, I think, are helpful. Establishing a molecular tumor board, if you don't have that at a hospital, where you can, give those physicians that are maybe older and they haven't been exposed to a lot of this genomic stuff, a little bit more coaching and help, in making decisions. I think you want to have, as a hospital, and I've experienced this firsthand because I've been to 5 or 6 different academic cancer centers. And so I've seen ones that have really, really good relationships in getting compassionate use and getting access to drugs that are not on label, because that's a big thing, right? When you sequence a person's tumor and you identify what's driving it, there may not be an FDA approved drug that's for your indication, but chances are there is an FDA approved drug that might be for some other indication. You can get access to it if you can show that you're a good match, but you've got to have the pathways involved with the pharmaceutical companies to get compassionate use or something to kind of expedite that for the patient when they need it. And again, I think some of the clinical decision support tools that are coming out of some of those large commercial diagnostic testing companies that are built for physicians that they can give access to are really, really handy. And so, I think those things would improve the pathways and making sure that they work for this new world that we live in.
Any other comments? Anybody want to comment?
I'll have comment.
Great.
As I always do. Well, I was doing a little bit of research going, when I think of pathways, I'm like, it's like step by step by step in, direction. And I think that's good. But I also think that can be bad because I think people can get tunneled into that and you get stuck in a routine. And you see this, I certainly have seen this in my days of healthcare. But I was looking, I was actually reading something on Geisinger, which is a big healthcare, in Pennsylvania. And they addressed this issue of pathways where they actually developed their electronic medical record in their system to talk to each other. Yay! And not only that, but they also incorporated, this takes a village. This is not one specialty or one subset, but it takes a village. And what they have done, and of course, they're in the beginning stages of it, but it's a continuing event where they have incorporated people to continue to feed into these pathways and to keep them current so that healthcare professionals who are very busy and, can't always go back and look at the research, but have people fill in. And I'm like, whoa, that's a great idea to think about continuing on, because we are only going forward with the thought of precision health and biomarkers and how do you stay current with that. And I think that they might have something here. But again, it takes a village to bring everybody together and to speak the same language and be working for the same cause. So I'm anxious to see how they go, how they turn out.
Thank you.
Yeah, I would, add on to that. And I think kind of marry, what Dot said and Bryce, because I think those are, the clinical decision support tools are helpful, and having the labs more integrated into the health systems are helpful. And it's something we're working on at the University of Iowa, is updating the EHR, be more like Geisinger and Penn. But it's also expensive, and you have to have the people, like Dot said, to maintain it. And so I don't think every community health system is going to be able to have that. So how do you develop those relationships and the partnerships between the larger, medical centers and the community health centers to be able to maintain those and be able to identify the patient for the right clinical trial and, and the off-label drug use and things like that. So I think it really does take, those networks. And that's where groups like, the Iowa Cancer Consortium, where you're, a resource for the whole state, can really help, I think, in bringing these services and bringing the right people to the table so that you can have that communication and develop those relationships.
Okay, thank you. So I'm going to ask the panelists now to look into their admittedly fuzzy crystal ball. And we're sitting here 10 years from now and having another panel discussion on precision health. What do you think the greatest advances are going to be in the next 10 years? And again, this crystal ball is very fuzzy, but what would you hope to see at that point in time? And Dot, maybe I'll start with you.
Well, we're hearing a lot of buzz about this, but I'm really excited about it, is artificial intelligence. I really see that coming into healthcare in such a positive way and really helping, like I said, put all the data together and when we talk about individualized, personalized healthcare, you're looking at one person, what is different about that person that is unique, and they have an issue you need to treat. You can come to the database. This artificial intelligence will help them to identify what is specific about this patient that they can bring to figure out how to treat this patient. It might be different. You have two people with the same disease, but you have two different entities, and having artificial intelligence help you to understand the difference and predict, what therapeutic maybe will work for that patient. That's my dream and idea that I don't think I'm very far off. I think it's happening.
Okay.
My turn?
Sure, Jackie.
So, as Dr. Weiner mentioned, government is always about 10 years behind on these advancements. But I hopefully see more targeted treatment. And as a personal goal, it would be nice to pass policy that is comprehensive and covers those future advancements now. When we think about passing policy, we're trying to pass comprehensive policy. So when those new advances are created, they fall into that bucket already that is covered, instead of us trying to play catch up. So in 10 years, hopefully we will have comprehensive biomarker coverage and many, many new treatments.
Thank you. Colleen?
Yeah, I think mine is a little bit more of like what I hope is in the crystal ball, I guess. And what I really hope is that we have more consistent access for all patients. And I think we have a shot at that, because there is a lot of people are worried about this and are talking about it, which is the first step. And we need to make sure that everybody has, that can benefit from these advancements. Bryce, I love you, but I hope in 10 years, everybody's like you and you're no longer, kind of the poster child for this. I hope we see everybody having the same access. And I think in order to do that, we're going to need innovations in education, because like you mentioned, Dr. Weiner, this stuff is coming so rapidly and so quickly, and we're all inundated with so much information. How do we actually get this to the providers in a way that they can quickly, understand it and are more comfortable using these advancements so that patients do have more access? We also need to do a better job educating, our general public and our patients so that they know to ask the questions and they feel comfortable picking up the phone like Bryce does and, making those calls. And so I think in a rural state like Iowa, I really would love to see in 10 years that the access question, we're not having that same conversation in 10 years, that everybody has access to, having their tumor sequenced, their germline DNA sequenced, having, the access to the treatments and moving forward so that the patient and their provider can make the best, informed decisions for what's going to be best for that patient, knowing that it could evolve during the course and get to that, chronic manageable disease state that, Bryce has alluded to.
And Bryce?
Yeah, so when I look in the crystal ball, I'll tell you what I want to see, but it's going to require that some fundamental things shift, I think. And so what I would love to see in 10 years from now is a robust marketplace of apps and tools that patients can use and that physicians can use. And, in some ways, it should just be like online retail, right? I mean, today when we go, we want to start shopping for something, or we do a Google search on something, next thing you know, you've got an ad coming from some other company because they know what you already wanted, what you're looking for. And like, we need to be able to get to that place in healthcare where doctors have access to so many tools, patients have access to, clinical trial matchers and, help with understanding your biomarkers and, all these kind of things. But in order to get there, you need data liquidity. I'm a tech guy, right? Like, and until we make this data extremely liquid and usable, we're not going to get there. And I think in the healthcare space, there's just too much regulations and mean, privacy is important, but we're never going to really make a lot of innovation unless we free up a lot of this data that's siloed and stuck in institutions today. So I feel like that, policy needs to look at that. And, Biden, even before he was president, when he was driving the moonshot stuff, he was hounding, the legislation branch of our government, just telling them like, look, you shouldn't be hoarding this data because the data isn't the IP. The IP is the analytics and the insights that you get out of data. And the only way you're going to get that is if you start combining large amounts of data and then you find patterns that you're not going to be able to find otherwise. And so I'm hoping that we get there. Like Dot said, I agree. I think AI and analytics are going to be everywhere. But again, it's only going to be everywhere if we can make the entrepreneurs and the innovators out there, give them something to play with. And if it's all hoarded up and locked up and siloed, then they're never going to get this opportunity. So the opportunity is there. We just have to free up this data and make it more available for people.
Great. So before we open it up for just general questions, maybe I can ask each of the panelists, is there anything else about precision health that we haven't covered that you'd like to speak to or say at this point?
What I would like to say about precision health is I would like to see equality. We are so needed. I mean, clinical trials are pathetic. We know that this type of patient maybe responds, but how do we know everybody responds? We really need involvement. We need education to not only the public, but the healthcare professionals. They need to understand the importance of this early detection and testing. Testing, do you know that 2 years ago at the Association of Clinical Oncology, they did a huge, that their whole program was based on health equity. And at that time, less than 50% of late-stage non-small cell lung cancer patients were being tested. That's horrible. That's horrible. And why is that? Well, there's many reasons. So you're right. We have to get policymakers educated about this, but we also have to get payers on board to understand this is not experimental medicine. This is, 60% of patients with late-stage lung cancer they'll find an actionable biomarker. That's impressive. And we're not even testing to get on a targeted, when I say actionable, I mean there's a drug out there for these people. So we have to think about that. And then we have clinical trials, because that's where our clinical trials are. They're looking at these new mutations that we don't know anything about, but they're comparing that pathophysiology is what's that mutation doing and what is this drug, how's this going to fix it? And that's why clinical trials are so beneficial today, but we have to take it to everyone, not just few people, and we have to open it up to everybody. And biomarker testing has to be paid for, period.
Okay, thank you. Jackie?
Yeah, so I was trying to think of what I would want you to know, but I think it's more of a question of what I should know. I'm just one person in the state, and I'm bringing this to the legislature to talk about. But if we think it's more valuable to hold, maybe a roundtable to talk about this issue in your county, or hold a meeting in your county, please reach out. I don't know what's happening in every county and every state, so I really encourage you to bring it to me as well, because I'm here to listen and I'm here to be a resource as well.
Thank you. Colleen?
Yeah, I think along those lines, we also have to listen to how we can best help our providers be able to do this, and talking to them. I know I had a friend in California, and on her 45th birthday, got a MyChart message from her doctor at Kaiser saying, hey, I just sent you something in the mail. It was her goal. She turned 45, automatically was sent a Cologuard test just to improve, the screening rates. And whereas, myself, my husband, when we turned 45, we had to ask, can we get screened? Can we get signed up for a colonoscopy? I know that, right? I'm in healthcare, I'm in genetics. I'm saying, I know what the guidelines are, and we now meet guidelines. And I had to explain the guidelines to my family, care doctor who is really good, but yet like still isn't up to date on all those new guidelines. And so if I'm having to like advocate for this, then I know there's a lot of people who aren't. And how do we get to a system where we can help the providers stay up to date on those guidelines and, implement things where they do send out, automated messages and get the patients involved. And also so the patients understand, that why they're having, the Cologuard test sent to them for their 45th birthday present from their doctor.
Thank you. And as is always appropriate, the patient advocate should have the last word. Bryce?
Well, I'm going to put my tech hat on for a second, because for a long time, I worked at Intel Corporation, and we had a group that worked with, the health and life sciences sector. And, it's not just us, Google, Amazon, Microsoft, Apple. I mean, they're all like, precision health is like the big buzz term right now. And a lot of these tech companies want to partner with organizations in the healthcare space that have a lot of data that just, they don't know how to turn that data on and how to use it. And so, for Iowa, I would consider, the advantages that could come with partnering with a large tech company that could help you really mine that data and do something useful with it. And, Dot mentioned Geisinger. It's amazing what Geisinger's been able to do by partnering with tech companies. They have taken precision health, and now they're really focused on prevention, before you even get sick, and that could be everything from like every patient gets genetic testing so they can understand, what you're predisposed to so they can intervene early. I know like Montefiore in the Bronx, we worked a lot with them. So what makes them unique? Well, 80% of their patient population is Medicaid, right? So, when you have a hospital like that, you don't want people coming in with acute care issues. You want to intervene early before they even get sick. So it's really important to know those patients, look at all the data, and to predict things before they even happen. And, there's a lot of examples of that where, working with a tech company, getting access to that data and helping them come up with new ways to predict and prevent illness has been really successful. So I would look into partnerships with tech companies.
Great, thank you. So Kelly, it looks like we have about 10 minutes for questions. Okay. I'm usually the one that asks the first one, but I've already asked 5, so.
Hi, everyone. Insay Witherspoon with the Children's Environmental Health Network. I'm going to be talking the next segment, so really appreciate all of our speakers. And I guess I just wanted to make a comment on your last question. My crystal ball wish would be that there would be a much more intentional marriage between genetic counseling and all the importance of this session, as well as the environmental health contributors, as Dot had mentioned, to many, if not most of the cases of different forms of cancer, because even with the genetic screening, we are still going to miss. Even with the best of behavior lifestyles, we will still miss and we will still see an increase in cancer incidence. So we don't want to be looking at this 10 years and wondering what could we have done. We know that there's a very important opportunity right now to prevent, in many cases, certain onsets of cancer versus putting the onus and responsibility, I think, on the caretakers as well as the patients themselves. So that would be my wish.
Thank you.
I would just follow up, from the genetic counseling perspective, we do talk with patients a lot that it's not all genetic. And we do, ask about those environmental factors and the family history. And sometimes patients just think like the genetic test is the magic answer. And it's not going to always, depending on which one. Often genetic counselors are talking more about the germline or what you're born with. But, I think helping people understand how all these things come into play and work together are really important.
And I do know that there is more testing going on in newborns, and newborns especially with high risk. And I know there's a physician in, I think, Washington State area where he is testing whole genome sequencing on all newborns that are high risk. And the goal is to, number one, identify if there is, a disease that that we're unaware of, number one. Number two is to prevent this disease. How can we prevent this disease from occurring? So there are those forward thinkers out there that are doing that to prevent that and to help in ways that I think technology is critical at this time to really understand, what is possible for this high-risk population, but then what is it going to be like for everyone someday? It might be.
I do have to push back a little on that. So I think what you're referring to is like Project Baby Bear and Project Baby Deer, and there's like 5 state Medicaids that are covering the whole genome sequencing of newborns. And I think that's great. And I am a huge proponent, and actually just brought this to our dean, last week, saying like, we need to be doing this, right? And Illumina called and they want to partner with us in Iowa on that. And that is fantastic. I am a huge supporter. But I think when we're talking about a disease with a later onset like cancer, we do also have to balance it with the patient autonomy. And, are we going to sequence every newborn for the risk for breast cancer? I would push back and say no, especially if it's a sick newborn in the NICU, we want to know, how do we get this baby, healthy as quickly as possible, and how do we get them out? And the risk for cancer, while cancer is very near and dear to my heart, I would say that needs to be a conversation later on when they can be more informed in that discussion. Obviously, there's some cancers that are at risk, for childhood, and those would be ones we would want to consider incorporating in that. But a germline risk for breast cancer, for colon cancer, those would be things we would want to wait till the individual is closer to 18. As a genetic counselor, that's my perspective.
No, I'm sorry. I was thinking of all diseases, not cancer, but cystic fibrosis, things that,
Yeah.
Okay. So being African American, for the past 50 years plus, we have lost our identity due to, say, slavery and stuff like that. So my breast cancer doctor used to tell patients that if you're not going to be, if you want genetic testing, make sure you have the insurance that you're not going to be losing for the next 10 years. Because once you get this genetic testing, insurance companies won't be able, they'll deny you off top. Are you guys having a lot of patients deny getting the genetic testing?
This is a really important question, and Colleen is an expert on that.
Yes. So there's a couple of laws. One is the Genetic Information Non-Discrimination Act that would prevent discrimination about genetic testing, but also what we call big genetic, which would include your family history. So one of the things the genetic counselors will do is they will talk to patients about insurance risks and insurance discrimination and where that would be. We typically do not see that very often for health insurance. Where you may see it is more in the life insurance, but not all providers understand the nuances. They don't also understand the loopholes to the laws, but there's other laws that have, with the Affordable Care Act, there's other protections in place as well. And so it is something we do discuss with our patients if they're making that decision about having genetic testing is, should we do this? Some states have tried to fill some of those gaps by with the legislature and passing laws to kind of fill some of those holes. But for the most part, we're not seeing a lot of it for health insurance. It also protects against employment discrimination as well. But the life insurance, long-term care, and disability insurance, those are not protected. And so those are things where you may want to get those in place. If you have a strong family history, they're going to know that. Once you have cancer, that supersedes any kind of genetic test, because a genetic test only tells you you're at risk for disease. There's not a genetic test yet for cancer that says you will 100% develop this disease. So once you have a diagnosis of cancer, then that's what the insurance companies will use, not any genetic test results. But it is a really important question and a conversation you should have, and genetic counselors are really well positioned for that conversation.
We have time for one more question, I think. Yep.
Rachel from the Iowa Cancer Consortium. I know just enough about biomarker testing to be dangerous, but I was just curious, if I was talking to my dad or my grandpa about biomarker testing, is there some analogy to a car or something else, like very visual, to kind of say, like, this is retrofitted for you? I was just curious if there's something off the top of your head that you use.
I may actually answer this one that I've used with patients before. And I've said it's like opening the hood of the car, that you're actually trying to look at what is going wrong under the hood and to identify it so you can take care of it right there mechanically, as opposed to just banging the roof of the car with the sledgehammer, which is what, unfortunately, in oncology we've done for some time. So that's a metaphor that I've used. Any others?
That's a good one.
I'm curious, Bryce, how would you describe it?
Yeah. Well, I've always just been like, you got to really understand what's driving your disease, because everybody's unique and different. And there is no one size fits all. I mean, even in, you take any individual cancer. We talked about non-small cell lung cancer, and everybody knows how critical that is. I mean, it would almost be medical malpractice to not profile someone with non-small cell lung cancer today. Yeah, I don't know if I have a great analogy. I love what was just described. I just think it's really, really critical to understand what's driving a person's disease. And, one of the things that that's been useful when I talk to certain people is, someone will get diagnosed with, breast cancer or prostate cancer, and they're told it's really aggressive. And it's like, oh, okay, but you're going to go on the same treatments that everybody else gets, and you're just going to hope for a better outcome? Is that what you're going to do? Because you've just been told yours is more aggressive, yet you're getting the same treatments as everybody else. Does that make sense to you? So, and I know that was with me in my case. It's like, why would I was told that my cancer was more aggressive than the average guy, yet I'm just supposed to go on the same treatments as everybody else does and just hope for the best? That just seems so odd to me. So, being able to understand what's driving your disease and then open up new doors just gives you hope. And not only does it give you hope as a patient, but it empowers you, because once you understand that your cancer is driven by something unique and then you can get on a treatment for it, it gets you more engaged and empowered in your care versus just kind of going through the motions if you are getting the same thing as everybody else does. So.
I think Bryce brings up a really important distinction in biomarkers, and that's the difference between a prognostic biomarker, which is going to tell you, how is a patient going to do, versus an actionable biomarker that's going to really direct the therapy that you're going to receive. And they both can be important, but obviously the actionable biomarkers are the ones that really are important to identify.
Yeah, and can I just add one thing?
Yeah.
Oh. Well, I just wanted to add one thing to that too. I think clinical actionability, the definition needs to be much better than what a lot of oncologists look at it today. I think a lot of doctors think of clinical actionability as, oh, okay, there's something FDA approved for your indication for this. And that's too narrow of a definition. I think, to me, clinical actionability means there is something that could either be FDA approved for your cancer, it's FDA approved for some other cancer, but you could get it as an off-label thing, or it's just opening up a clinical trial that would be a good fit for you. And when you look at it that way, you're going to most likely find some match if you do some cancer genomic profile.
I agree with you, and I think the word predictive has been used a lot, and now they're wanting, more and more healthcare professionals want to what can we predict what their outcomes are going to be? And I think that's part of the research, looking at that, saying how can we predict and what do we know? And you're right, that will make a decision of what therapy would be best for that individual patient.
Okay, well, I would like to thank the panel for just a superb discussion of a really complicated topic. So thank you very much.